Good morning, sir.
Ram, welcome, Nilesh.
Can I request the organizing team to just put up my slides?
Yeah, we will share it.
Yeah, good morning. I'll be presenting the key link 012 study. This is by Salma Jabor from the Rutgers Cancer Institute, New Jersey. And this study was presented at the ESMO Virtual Congress 2020. Next slide, please. So we know that for patients who have stage 3 unresectable, locally advanced lung cancer, since the last few years, there has been a standard of care, and the standard of care has been durvalumab. So durvalumab, which is an anti-PD-L1 antibody, is approved for unresectable stage 3 NSCLC without disease progression following concurrent CTRT. So concurrent CTRT remains a standard of care, and maintenance therapy after this in patients who have not progressed is today the standard of care for patients with stage 3 lung cancer. Pembrolizumab, which is also an anti-PD-L1 antibody, is the standard of care for those patients who have metastatic NSCLC, either as monotherapy or in combination with chemotherapy, depending on the biomarker expression. There have also been early trials of pembrolizumab in the setting of stage 3 lung cancer, where it is combined with concurrent CTRT, either given concurrently or subsequently. And this has shown acceptable tolerance as well as a promising PFS in patients with unresectable stage 3 non-small cell lung cancer. Now, these initial studies have been smaller studies and single-arm studies. There is also early data that suggests that PARP inhibitors, when combined with the anti-PD-L1 molecules, can enhance the treatment effects. So the key link 012 is a global phase 3 randomized placebo and active controlled double-blind study that evaluates pembrolizumab with concurrent CTRT, followed by pembrolizumab with either placebo or PARP inhibitor olaparib, that is group A and group B, versus the standard of care, which is concurrent chemoradiation, followed by durvalumab, which is group C. And this is in patients with unresectable, locally advanced stage 3 lung cancer. So this is the study design. Patients more than 18 years who have stage 3, either A to C, non-small cell lung cancer, and who are ineligible for any curative surgery, and who have a performance status of 0 to 1, are randomized into 3 groups. Group A is the pembrolizumab with concurrent CTRT, followed by pembrolizumab for a period of 1 year, along with olaparib as a placebo olaparib. Group B has a similar design, but olaparib is added to this combination for a period of 1 year. And Group C is a standard arm or the control arm, which includes concurrent CTRT followed by durvalumab for a period of 1 year. The choice of chemotherapy, can I go to the previous slide, please? The choice of chemotherapy is either basically a platinum doublet. So it is cisplatin, etoposide, and paclitaxel for the squamous, and it is cisplatin and pemetrexed for the non-squamous. Radiation is standard 60 gray during cycle 2 and cycle 3. Next slide, please. So just to note in the exclusion criteria, in view of the drugs that are being co-administered with radiation in this setting, patients who have a history of pneumonitis or interstitial lung disease, and as well as patients who have features suggestive of AML or MDS were excluded in this group of patients. Next slide, please. So the primary objective was to evaluate the following in group A and B versus group C. One was the PFS as per the blinded independent central review, as well as the overall survival. And the secondary endpoints included safety and tolerability, the overall response rate, the duration of response, and several patient-related outcomes. Next slide, please. There were also some exploratory objectives. So they will be assessing the circulating tumor DNA during the course of its treatment and correlate this with efficacy endpoints. They would try to identify molecular biomarkers that may indicate clinical response or resistance and safety. They will also evaluate the effect of PD-L1 expression on these similar efficacy endpoints, as well as evaluate the following in group A, B, and C regarding the PFS2, as well as the time to the first anti-cancer therapy and the second anti-cancer therapy, and several other economic models. Next slide, please. So this presentation was a trial methodology presentation. This study has been initiated just last year in July 2020 at 204 sites in 24 countries, and is currently undergoing recruitment. So the earliest we would probably get any interim result would be somewhere in 2024 or 2025. But there were some important points that this trial has tried to address. And can I have the next slide, please? So as I went through this trial, I thought that there were three important questions that this trial is trying to address. The standard of care today for stage 3 non-small cell lung cancer that is unresectable includes the use of chemoradiation as the main treatment. And in patients who have stable disease or who do respond and do not progress, after a period of 2 months, these patients are put on maintenance durvalumab. Now, there is a problem in that the IO or the anti-PD-L1 drug is initiated much later, almost 3 or 4 months after diagnosis. And from our data in metastatic non-small cell lung cancer, we do know that earlier use of immunotherapy will always be important in decreasing the risk of distant metastasis as well as in preventing early progression. So can we initiate the immunotherapy right at the diagnosis along with concurrent CTRT? That is one important question that this trial is going to address. For so many years, the trials tried to segregate and keep the radiation separate from the immunotherapy. And the main reason was the concern or the risk of pneumonitis. So the same author, Dr. Salma Jabor, this year in JAMA Oncology has presented the Keynote 799 study, which was a phase 2 open label trial in stage 3 non-small cell lung cancer, where patients were treated with pembrolizumab along with chemoradiation, followed by pembrolizumab, in a similar way as this trial has tried to address. And in that trial, the incidence of pneumonitis was 8% in the squamous arm and 6.9% in the squamous plus non-squamous arm. And this incidence of pneumonitis between 6 to 8% is comparable to that which is achieved that is seen in patients who receive single agent pembrolizumab or those who just receive chemoradiation. So what is important is that addition of radiation does not, addition of of pembrolizumab would not increase the risk of pneumonitis when given with CTRT. So that is the second important point. Third, can I go to the next slide? Yeah. So the third important point was the rationale of combining IO with PARP inhibitors. So similar to breast cancer and ovarian cancer, there have been several studies that have shown that homologous recombination genes, including the ATM, the BRCA1 and the BRCA2, have been found to be frequently mutated in lung cancer patients. And these are somatic mutations. So there was a study where across tumor types in lung cancer, the prevalence was as high as 34%. And we know that PARP inhibitors selectively target cancer cells who have DNA repair deficiencies, like those caused by the BRCA1 mutations, and in lung cancer specifically, the ERCC1 defects, which also causes an impaired DNA repair. And there is strong preclinical rationale for using PARP inhibitors as an immunomodulatory drug in appropriately selected molecular populations. So PARP inhibitors have also shown to potentiate the interferon-induced PD-L1 expression, not only in cell lines, but also in fresh patient tissue. So this is an intrinsic concept. Can you add the benefit of PARP inhibitors as an immunomodulation as well as in patients who have HR gene mutations? So these are three important points that this trial tries to address, and it will take time, almost 3 to 4 years by the time we have some interim results. But I think it is a very interesting study, and I would look forward for its analysis. That's my last slide. Thank you so much.
Yeah, thank you, Dr. Nilesh.
Thank you, Nilesh. The number of cases they have planned is somewhere around 800 plus.
Correct.
And multi-centers all over the world. Are you or TMH a part of the study?
So I don't think any center in India is a part of the study. From what I could understand, most of them are China, Japan, and North America.
Oh, okay.
But I'm not specific. I'm not very sure.
Okay, okay. Because in India, one of the common cancers and again, one of the common stages, maybe cost-wise, any comments on this?
So I think cost is a major limitation for most of our patients because irrespective of which IO is used in this setting, it does become expensive for most of our patients. Having said that, this is one group of patients who actually sit on the borderline between cure and incurable disease, and this is the best we can offer as of date in this setting.
Thank you. My co-chair, please. Thank you, Dr. Nilesh.
Thank you, sir.